From Microbe TV, this is Infectious Disease Puscast, episode 10, recorded on August 31st, 2022. I'm Daniel Griffin, and joining me today is Sara Dong.
Hello, everyone.
Welcome to another Puscast. References, as always, are available in our show notes at Microbe TV, the home of our growing multimedia empire.
Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. Now, on to the literature, shall we?
All right. Well, we will start with viral, and remember to listen to TWIV clinical updates for COVID, monkeypox, and polio-related information. But we are going to start with tomato flu outbreak in India, published in the Lancet Respiratory Medicine. We are hearing that a new illness known as tomato flu or tomato fever has emerged in India in the state of Kerala in children younger than 5. The tomato flu was first identified in the Kollam district of Kerala on May 6, 2022. And as of July 26, 2022, more than 82 children younger than 5 with the infection had been reported to the local government hospitals. The primary symptoms observed in children with tomato flu are high fever, rashes, intense pain in joints. Now, tomato flu gained its name on the basis of the eruption of red and painful blisters throughout the body that gradually enlarged to the size of a tomato. Now, what kind of a tomato? A beefsteak? A cherry tomato? A plum tomato? Well, they go on to say that these blisters resemble those seen with the monkeypox virus in young individuals. Wow. Is monkeypox now so common? We have monkeypox-like rash as a descriptor. There's some evidence that this is actually not a new viral disease and perhaps is just a manifestation of good old Coxsackie A16, based on some sequence data out of the UK. All right. Which size tomatoes are they talking about, Sara? I couldn't figure it out.
In my head, I pictured cherry tomatoes when I first was reading it. But
All right.
yeah.
Maybe in Kerala they have tiny little tomatoes. So in the future, tomatoes come in various sizes. You can't say it's the size of a tomato. Who knows what that is? All right. The article, Oral Rabies Vaccination of Dogs, Experiences from a Field Trial in Namibia, published in PLOS Neglected Tropical Diseases. I recently had an interesting rabies question. It was just like a board question. It was a local infectious disease doctor realizes they've been living with a bat inside their home for 3 days in the living room where people like to nap, including the husband, the children. They get that bat, they get a container, and of course they send me a video because, well, I need proof because I might not believe them otherwise. And the question is, what do you do? Well, so when the man comes to take the bat away, they say, well, you're going to take that to the DOH and get it tested for rabies. Sort of a little bit of a cagey response leads them to believe what ultimately happens, that bat ends up not at the DOH. So let me just share the author's summary of this article. Rabies in dogs can be prevented by vaccination, and this approach has become a cornerstone in the control and eventual elimination of the disease. However, vaccinating hard-to-reach, often free-roaming dogs is a challenge. Okay. A potential solution would be to vaccinate these dogs using oral baits filled with a vaccine. So in this study, they assessed the acceptability of oral rabies vaccination in Namibian dogs under field conditions. The results demonstrate that the method is acceptable both to the owners and the dogs. Well, I thought these were feral dogs, with a high uptake of the egg-flavored bait. So we have just discovered that dogs eat stuff, particularly when it tastes like eggs. This supports the potential oral rabies vaccination approach to contribute to vaccination programs where parenteral vaccination alone failed to reach sufficient vaccination coverage in the dog population. All right.
The egg surprised me.
Yeah, I think cheese, there's a lot of choices here. Butter flavored. All right. Let's move on to bacterial. And I'm hoping that we can get a little bit of a deep dive into this next article. At one of our hospitals that specializes in orthopedic procedures, a major challenge for us as infectious disease consultants is infection of these prosthetic joints. So the paper Repeat Revision of Total Knee Replacement, TKR, for failed management of periprosthetic infection has long-term success, but often requires multiple operations, a case control study. So this is a retrospective analysis performed of 32 patients who underwent revision knee arthroplasty, having already undergone at least one previous two-stage exchange for PJI, prosthetic joint infection, with a minimum follow-up of 2 years for the alive patients. The patients that did not survive were not followed. This study population had revision surgery following previous two-stage knee arthroplasty for PJI. These 32 patients were compared with 32 patients from a control group who underwent two-stage revision surgery of primary knee replacements for the prosthetic joint infection. Now, they reported in the small cohort that successful eradication of infection was achieved in 50% of patients following revision surgery, compared with 91% following two-stage exchange of primary. So, not so great. 44% of the patients required further reoperation, compared with only 9% in the primary group. Amputation was required in one case, with 92% of patients who had infection controlled by debridement, antibiotics, and implant retention. Debridement, antibiotics, implant retention, further revision surgery, or arthrodesis. 2 patients died with infection, 6%, and the long-term rate for infection control was ultimately 91%. The mean number of procedures following surgery for the revision group was 2.8, compared with 0.13 for the primary two-stage group. 5-year patient survival was 90.6%, and the limb salvage rate for the revision cohort was 97%. So not very exciting, not very encouraging when we have to do a revision of a infected joint.
Yeah, I do feel like the authors were trying to have a little bit of optimism, because you could also take away the message that, like, even though those patients, there were more initial sort of quote failures that were higher when they had revision, that many of those patients did ultimately gain control, and using the marker of they were able to keep their limb, which is a good indicator of their quality of life. But it is hard to picture a lot of patients who have recurrent infections that could undergo 3 surgeries. So I think those are the patients that aren't quite the ones that were in this study. But there's some space for optimism there. I think they were emphasizing how we really shouldn't abandon these patients in case they might ultimately be successful in the end. But yeah, I agree. Tough. These are really tough cases.
All right. The article Cat Scratch Disease, 9 years of experience at a pediatric center, was published in Open Forum Infectious Disease. And these are the results of a retrospective analysis of children presenting to a tertiary pediatric hospital in Atlanta, Georgia, between January 1, 2010 and December 31, 2018, who had serology, PCR, and or cytopathological results consistent with Bartonella Hensley infection. They also retrospectively reviewed veterinary diagnostic results performed at the University of Georgia from 2018 to 2020 to ascertain the burden of Bartonellosis in companion animals within the state. They identified 304 children with cat scratch disease over 9 years. I am back to Chrysalip's advice about deep frying those animals for childhood safety. The median age of child cases was 8. Oh my gosh, these poor little children with the undeep fried cats. About half of them were female. Almost all of them reported feline exposure. Feline is a fancy word for a cat, deep fried or otherwise. 22% reported canine exposure. Although lymphadenopathy was present on physical exam in the majority of cases, not always, so about 79%, atypical presentations lacking lymphadenopathy were also noted, about 20%. Among children with radiographic imaging, 36% had splenomegaly, 38% had splenic or hepatic microabscesses. Among veterinary data, Bartonella seroprevalence was 8% in all canines with a geographic distribution that spanned the state of Georgia.
I do really like Bartonella. Always on the hunt for that. It's pretty cool that they had the information about the companion dogs too.
Yes.
Um, well, our next article I pulled from Transplant Infectious Diseases Treatment of Asymptomatic Bacteriuria in the First 2 months After Kidney Transplant, a Controlled Clinical Trial. So, this was a randomized, single blinded trial of kidney transplant recipients in a single center in Mexico. They took 3 urine cultures. The first after removal of the urinary catheter, so after the second urination after the catheter was out, on the third week post transplant, and then before removal of the ureteral catheter. And if patients had asymptomatic bacteria, they would get either no treatment or 5 days of antibiotics based on whatever ID recommended. And then if they develop UTI or pyelo, they got 7 days of antibiotics for cystitis or 10 to 14 for pyelo. So this excluded patients who had any sort of urological complication. And then if they certainly didn't have a urinary catheter or ureteral cath removal during the study period. So they found that screening and treatment of asymptomatic bacteria in the first 2 months of follow up did not decrease the incidence of UTI and pyelo. It actually increased a little bit in the study, despite there being a greater rate of asymptomatic bacteria in the control group. And so those numbers, the UTI was present in 10% versus 25% in the not treated versus treated groups. And then for pyelo, it was 2.5 versus 15%. Um, so I think this is good news, what I think we expected. There's been other studies looking at a little bit beyond 2 months that also shown that there's not a significant difference in how often people get UTIs, whether or not you treat their asymptomatic bacteria. All that seems to happen is that they get more resistant bugs down the road. A small study, but generally, I think at this point we can agree there's very few reasons we need to treat asymptomatic bacteria. So I will end with symptom-free pee, let it be.
Oh, I like that. I like that. Yeah, I will say that asymptomatic bacteriuria and the not treating thereof is a little bit of a pet peeve for me. I'm a big
Of
pet person.
every
I have
ID doctor on earth.
lots of pet peeves. And I was taught in my training, and the current recommendations are not to treat asymptomatic bacteria unless a person is pregnant or there is a planned urological procedure. But if folks are basing their practice on up to date, you will notice that recent kidney transplant is on that list. But is that evidence based? No, it is not evidence based.
Yeah.
So if you get the call, this is your opportunity to do the right thing. Do not give people, because as we saw in this study, it was not helpful.
Yeah.
Actually, potentially harmful. Right.
Yeah.
So let's not do things that are harmful. Let's not recommend. It's not a great way for you to please those people calling you for consults. They're calling you for good evidence-based guidance.
Yeah.
So, all right. The article, Shorter Antibiotic Courses in the Immunocompromised, The Impossible Dream, was published in CMI. These are the results of a critical review of the literature that assesses shorter antibiotic courses in immunocompromised patients, specifically among solid organ transplant recipients and neutropenic fever syndromes among patients on anti-neoplastic chemotherapy and undergoing hematopoietic stem cell transplant. The author searched PubMed, Embase, Medline, and clinical guidelines documents. And then they went on to report that among organ transplant recipients, the majority of studies assessing outcomes associated with shorter course antibiotics have been retrospective. They did suggest that clinical improvement guided adoption of shorter courses has been associated with fewer antibiotic days. I think I got that. And similar rates of fever, recurrence, and mortality. What is it about studies of shorter antibiotic courses where they show you that that is associated with less days on antibiotics? That's the whole study. All right.
Well, I will move us into a different arena away from transplants. Risk of cardiovascular implantable electronic device infection in patients presenting with gram-negative bacteremia. So this was an OFID. So cardiac device infections from gram-negative bugs is relatively rare. And this retrospective study of about 130 patients took a look at the rates of these infections and then whether or not certain gram-negatives are more common. And so the overall rate of device infection in this paper was 11%. The median time from device implantation to infection was 4 years, and E. coli was the most common of the gram negatives identified, accounting for about half of those cases. Very few patients had device removal. There were 4 who underwent complete extraction. And so I think a lot of this in the discussion really focused on how the case definitions for device infection um, is challenging when we're comparing studies and then trying to apply the guidelines and assist in our decision to remove the device for these patients who have gram-negative infection. And I think the other takeaway was a little caution sign with serratia, which was associated with higher rates of device infections. And I will say, whenever you have a patient with a device who has serratia in the bloodstream, it does make me nervous and raises that question of if you should push for a TEE, but that's a separate discussion, I think.
Yeah, this comes up a lot, actually,
Yeah.
as I think you just told us, 11% of the topic comes up a lot.
Yeah.
The data supports. And it is this issue. What do you do? Let's say someone has a pacer, they've got the wires. If it's
Yeah.
Staph aureus, some centers, some guidelines, a number of the guidelines just say take it out. If you don't see it on the TE, we're not looking under a microscope with a TE. And a very high issue. But I think some of the studies, and we'll talk about them as they come out, but it's not really clear that every single patient that has a device needs the device removed or even
Mm,
needs those leads removed. So,
yeah.
all right. At some point, we'll talk about serratia and Operation Sea Spray, but for another time. All right, modern solutions for ancient pathogens, direct pathogen sequencing for diagnosis of lepromatous leprosy and cerebral coenerosis. I always pick these ones that are so hard to pronounce. This was also published in Open Forum Infectious Disease. Leprosy, that's easy. It's an infection caused by Mycobacterium leprae and something that has actually shaped history. But what is this coenerosis, and why are we using modern molecular technology to diagnose this? And why are the two in the same article? Well, coenerosis is a tapeworm infection caused by those other tinea, those other tapeworms, Tinea multiceps, Tinea cerealis, Tinea broni, Tinea glomerulati, rather than by that good old Tinea solium that we normally think about. These are mainly infections of sheep, but they can infect humans. Symptoms basically develop wherever that cyst develops. Now, for the diagnosis of leprosy, this is actually quite a bit of challenge. I was in India where there was one place where they still knew how to inoculate the Mycobacterium leprae onto the mouse pads. And then the woman who did that was getting on in years, and there was concern when she retires, who else would learn this mouse pad Mycobacterium leprae culture technique? So there really is something to be said for using modern technology. So here, what they did is they used modern technology not only to make the diagnosis of these tough to make diagnoses, but also to look potentially at antimicrobial susceptibility.
Cool. This next one, I don't have any additional comments. In the European Journal of Clinical Microbiology and Infectious Diseases, which I don't know that we've had a paper from this, but treatment duration for central line associated infection caused by Enterococcus species, a retrospective evaluation of a multi-center cohort. So, this observational retrospective multicenter study looked at 113 hospitalized patients with enterococcal CLABSI and found that patients receiving more than 7 days of treatment had similar 30-day mortality to those who received less than 7 days, even after some adjustments, suggesting that perhaps we could use a 7-day treatment course for uncomplicated enterococcal CLABSI. Just for some additional points here, endocarditis was excluded, and the central line was removed in 82% within a median of 3 days. So the old IDSA clinical practice guidelines for catheter-associated bloodstream infections, it's from 2009, but I think most of us still use it because there's not something that is more recent. But that does suggest 7 to 14 days for enterococcus-associated bloodstream infections with an intravascular catheter in place. So more for the shorter is better camp for, enterococcus in particular. But hopefully we'll continue to see other things like this.
All right. The article, Amoxicillin versus other antibiotic agents for the treatment of acute otitis media in children, was published in the Journal of Pediatrics. Now, people often ask when you write for an, is this a strong antibiotic? Now, I think that this is an educational challenge. Are we hitting another pet peeve of mine? When I lend someone the keys to my car or house, is this a strong key? Is it going to start that engine really well? Is it going to open that front door? Um, you know, Antibiotics are not strong or weak. They are appropriate or inappropriate. You want the appropriate antibiotic that's going to get the job done, that's going to open that front door, that's going to start that car, that's going to cure that infection. You're not asking for a sledgehammer. A sledgehammer will open up a front door, but oh my gosh, what does it leave that front door looking like? And I think we do the same thing with our powerful antibiotics. Yes, I will treat that otitis media in your child, but their gut will be wrecked. Their microbiome will be destroyed. Is that what you want? Do you want a strong antibiotic for your child or the appropriate antibiotic? So these are the results of a retrospective cohort study of children 6 months to 12 years of age with uncomplicated acute otitis media identified in a nationwide claims database. The primary exposure was antibiotic agent, and the primary outcomes were antibiotic treatment failure and recurrence. So, among over 1 million children included in the analysis, about half of them got amoxicillin, about 13.5 got amoxicillin clavulanate. That's that augmentin. That's the antibiotic we give to the mother in law to give her diarrhea at no extra benefit. Ceftonir, that's 20.6%, and 9.3% got azithromycin. Combined failure recurrence rates, who did the best? Amoxicillin only failed 1.7% of the time. That augmentin, amoxicillin clavulanate, mother-in-law antibiotic, it failed about 10 times as often, 11.3%. All that diarrhea and GI upset for naught. The ceftonir, 10%. The azithro, 9.8%. So all these had failure rates about 10 times that of the amoxicillin. So what is the strongest, most powerful, most appropriate? It's amoxicillin.
That may be your best article lead-in that you've had so far.
Okay. All right. I'm excited. But we got stuff in fungal to do as well. So, surveillance for coccidiomycosis, histoplasmosis, and blastomycosis, United States 2019. And this was published in the MMWR. Now, they have a nice introduction, which I really enjoyed. They lay out coccidiomycosis, histo, and blasto as fungal diseases that can infect anyone regardless of immune status. And they can progress to life-threatening severe pulmonary or disseminated disease. They also remind everyone that this is one of those risks of breathing, as infections are typically acquired by inhalation of fungal spores from the environment. So that evil miasma, that evil malaria. We even get to worry about climate change as the potential to expand the geographic range of cocci, histo, and blastomycosis in the United States and globally. Now, coccidiomycosis, also known as valley fever, and caused by Coccidioides immitis and Coccidioides Posidocil is most commonly acquired in the southwestern U.S., although it's also acquired as far north as Washington, the Great Pacific Northwest. Histoplasmosis, caused by Histoplasma capsulatum, is acquired primarily in central and eastern states. Although I will add, here in the Northeast, we see a lot of exposures from down there in the Caribbean, other endemic areas. Blastomycosis, caused primarily by Blastomyces dermatitis and Blastomyces gilchristi, is found in Midwest, South Central, and Southeastern states. And the recently described Blastomyces helicus has been found to cause illness in the Western U.S. So, to give us some perspective, in 2019, the CDC received over 20,000 Coxsackie case reports from 23 of the 27 states and jurisdictions where the disease is reportable. So that's a big one. And remember, when you're worried about that, you call the lab and you warn them, or they will not be your friends anymore. In 2019, the CDC reported over 1,000 cases of histo from a dozen states where the case is reportable. In 2019, CDC received 240 cases of blasto from 5 states. So not as many there. So perhaps the part I liked the best was there's a really nice link to the maps for the different pathogens. So I will put those in our show notes, and I encourage people to click and enjoy the CDC maps. I thought the big takeaway is that despite a limited amount of publications on these fungal pathogens do cause substantial illness in the United States, particularly Coxsackie in terms of the number of cases, right? Over 20,000. And don't forget, we probably miss a lot of cases. So perhaps in your next case of pneumonia, one should include fungal pathogens in the differential.
Love it. Yeah, I was reading about coccidioides not too long ago, and about how it's such a common cause of community-acquired pneumonia that oftentimes patients in endemic areas might be prescribed an antifungal. And it seemed so foreign because I haven't practiced in an area where that would have applied. But our other fungal paper today is from CID, Cryptococcal Antigenemia and Advanced HIV, Pathophysiology, Epidemiology, and Clinical Implications. So, screening cryptococcal antigen and preemptive treatment of those who are cryptococcal antigen positive with fluconazole is used as a way to prevent cryptococcal related meningitis and deaths among adults and adolescents living with HIV with a CD4 count less than 200. So, it's thought that about maybe a third of individuals with asymptomatic cryptococcal antigenemia have subclinical cryptococcal meningitis. And so there are certain countries, I think about 20, that have adopted large-scale screening and this preemptive treatment at various CD4 thresholds. The WHO uses the recommendations of screening in high prevalence areas among ART-naive patients with a CD4 count less than 100. So this review summarizes a lot of those studies that have looked at some of these programs that have used screening and preemptive treatment. But really the implementation of this is very variable, and how effective it is at reducing mortality is not quite as clear. But this is a really nice way if you want to get familiar and look at the background behind that. The other focus is on how patients with antigenemia still have higher mortality compared to those without antigenemia, despite antifungal treatment for reasons we don't totally understand. And, is that a combo of some patients getting suboptimal treatment with fluke monotherapy, or a component of sort of host susceptibility, meaning is there some sort of underlying defect or genetic predisposition that's beyond the fact that their CD4 count is depleted? So I think this is a really nice paper, and there's 2 really great figures. 2 and 3 are summarize a lot of these points. So I would recommend that people check this paper out.
All right. And parasitic. And remember to listen to This Week in Parasitism. The article, Intestinal Parasite Infection in the Augustinian Friars and General Population of Medieval Cambridge, UK, published in the International Journal of Paleopathology. So here, the investigators were looking at Augustinian friars from the 13th through 16th century and 25 burials from the the parishioners in 10th through 14th century Cambridge. They analyzed the sediment using microsieving digital light microscopy. I have to say, like the images, I was pretty impressed.
Yeah, that's pretty
They
cool.
found they found that the parasite prevalence in the friars was 58% and the parishioners was only 32%. It reminds me of the joke about why the cannibals got sick after eating the friars. Apparently, it was not the mistake of boiling them when it appears they were friars. It is just that they were incredibly wormy. All
I was
right.
shaking my head for people who are listening.
All right. All right, people, don't worry. Do not worry. I will not fail to take the opportunity to again say bad things about vancomycin. Nephrotoxicity of vancomycin in combination with beta-lactam agents. Ceftolozane tazobactam versus piperacillin tazobactam was published in CID. These are the results of a multi-center observational comparative study across the United States. The primary analysis was a composite outcome of acute kidney injury, AKI, risk injury failure, loss of kidney function, RIFLE, end-stage renal disease is the E, AKIN, acute kidney injury network criteria, or VAN, VAN, vancomycin-induced nephrotoxicity. So the authors suggest that going into this, we knew that vancomycin was a well-known renal toxic medication associated with acute kidney injury ranging from 5 to 43%. That's pretty broad. And there is evidence suggesting that there can be a 3 to 4-fold increased vancomycin associated renal toxicity when combined with Zosyn. Here they compared patients that were treated with ceftolozane tazobactam versus those that got Zosyn. And I think the easiest data to see is in table 2, where they see those that got the ceftolozane tazobactam had acute kidney injury about 12% of the time, where those that got the Zosyn combined with the vancomycin, twice that at 25%. So in folks getting vancomycin, adding Zosyn was associated with an odds ratio of 3.3, so more than 3 times as likely to get acute kidney injury. So I know that people are a little excited about that recent study, the very messy study that we've referred to, but still continue to be careful. And it gets better. It gets even better. Administration of a beta-lactam prior to vancomycin as the first dose of an antibiotic therapy improves survival in patients with bloodstream infections was published in CID. Or should I say it the other way? Giving the vanco first was associated with worse outcomes and more people dying. Well, we know that prompt initiation of antibiotic therapy improves the survival of patients with bloodstream infections, but which antibiotic in which order? So these are the results of a multi-center observational study of patients greater than or equal to 13 years of age with bloodstream infections to evaluate the association of the sequence of antibiotic administration with 7-day mortality. So administration of the beta-lactam agent prior to the vanco was associated with a 52% reduction in 70-day mortality. So 52% mortality benefit in 7-day mortality over those that got vanco first. Similar results were seen with 48-hour mortality. That was at 55% reduction. A little surprising, and I think this is a little surprising, even in those with methicillin-resistant Staph aureus with MRSA bloodstream infections, they really did not show improved survival. So in the words of James Cottrell and James Sander, the early beta-lactam catches the germ.
In intensive care medicine, I picked an article, Machines That Help Machines to Help Patients, Optimizing Antimicrobial Dosing in Patients Receiving Extracorporeal Membrane Oxygenation, ECMO, and Renal Replacement Therapy using dosing software. If you're lucky enough to work with an ID PharmD colleague, I am sure you have reached out to talk about selecting the right doses in these very ill patients. But this was a narrative review looking at the impact of ECMO and RRT on the pharmacokinetics of antibiotics. And I think covers a lot of the major concepts, such as drug sequestration with ECMO due to its large surface area. That's just one example. But there's also some really cool stuff in there about approaches we might use in the future, such as continuous biosensor therapeutic drug monitoring that then gets plugged into machines for AI data analysis and then precision dosing software. So things that could be on the horizon that are pretty interesting. But there's some really nice tables that summarize these concepts as well.
All right, just a couple articles to finish us off. In-person versus tele-infectious disease, tele-ID care is one better, published in Open Forum ID. And as we know, there are the majority of counties in the United States without ID docs. And Sarah's done a great job of proving, of showing, of sharing the literature that calling an ID doc is actually helpful. Imagine that. Well, here they found in the study compared to in-person, tele-ID received significantly more consults with similar outcomes for length of stay, transfers, readmission, and mortality. So maybe tele-ID is a way for the ID docs to reach more of those folks. And I did want to finish with the last article, the disproportionate impact of COVID-19 pandemic on healthcare-associated infections in community hospitals, need for expanding the ID workforce, published in CID. Basically, here what we saw is the incidence of a lot of these infections, those CLABCs, those central line associated bloodstream infections, those ventilator associated infections, those ventilator associated events were significantly increased, but particularly in community hospitals that lacked ID support. So perhaps a role here for tele-ID for these community hospitals.
Yeah. And that brings us to the end of this podcast. As always, the references for the show are available at microbe.tv, the home of our multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. We love to get your questions, comments, and paper suggestions, so keep sending those to puscast@microbe.tv and consider supporting the science shows of Microbe TV. Go to microbe.tv/contribute. Do that right now.
I'm Sara Dong. You can find me on Twitter at swindong, at Febrile Podcast, or at febrilepodcast.com.
And I'm Daniel Griffin, and you can find me at parasiteswithoutborders.com, on Twitter at Daniel Griffin MD, as well as on the other podcasts, This Week in Parasitism, This Week in Virology, Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, end dictation, and goodbye. Thanks for listening. We'll be back in 2 weeks.
Another Puscast is infectious.